So thank you for the kind introduction. I can skip mine now because you already know I'm a registered nurse specialized in oncology and hematology. I work for the University Hospital in Ghent, in Belgium. I have no conflicts of interest. So what is mobilization of hematopoietic stem cells? That's the main question. So maybe first, what is a hematopoietic stem cell? It's actually the human's body's raw material. So if you can see the pictures, if you see it on the left side, you see a lot of little stem cells going to school. They have career day and the teacher tells them they can be whatever they want. So that is actually what stem cells are. They have the capacity to differentiate and multiply into all types of blood cells, and they are situated in the bone marrow, the hematopoietic stem cells in the red bone marrow. What is the purpose of mobilization? So the goal of mobilization is actually a peripheral blood stem cell collection. And the goal of that collection is, of course, stem cell transplantation. In 1985, so that's not a long time ago, the first clinical attempts of trafficking hematopoietic stem cells into the peripheral bloodstream were made. Before that, so before the use of growth factors, the harvesting of hematopoietic cells went through bone marrow harvest. The biggest advantage of collecting stem cells through peripheral bloodstream is that you don't have the general anesthesia that you have with bone marrow harvest. On the other side, with bone marrow harvest, you don't need to use the growth factors. So you don't have the complications of the use of growth factors. Another advantage is that if you collect stem cells through peripheral bloodstream, you have a faster engraftment of your stem cells. So this is a little recap of what I already told. So you have the bone marrow, but the stem cells that are in the bone marrow have to go to the peripheral bloodstream. And that we can do by the use of the growth factors. Then about the mobilization. We have two types of donors. First of all, autologous donors. There the donor is the patient. We have two types of mobilization: without chemotherapy, that we call à blanc, or with chemotherapy. So the without chemotherapy part, there we start the growth factors 5 days before the first scheduled day of apheresis. The dose of the growth factors is actually always the same, so 10 microgram per kilogram body weight per day. We have no CD34 count. What is CD34? The other speaker already told it. It's actually stem cells express the cell surface marker antigen CD34. So if we do count in a blood draw of the CD34, we already more or less know if we will be able to do the apheresis, yes or no. So with an à blanc, so no chemotherapy, there is no CD34 count the day before apheresis, only at the first day of apheresis. A little point of attention there, with referred patients, the day that they come for the CD34 count is mostly the first day that they come into our hospital. So if you don't have that, then the first day of apheresis is the first day they come. So maybe it's a good idea to call them before they visit your hospital to give a little bit more explanation about where they have to go, how late, the logistic stuff. Which pre-count do we need to start an apheresis? That's 15 or more CD34 per microliter. And here you see the currently approved growth factors for mobilization in hematopoietic stem cells in Europe. The with chemotherapy part, so some people receive chemotherapy before they have the stem cell collection. Then the growth factors start not 5 days, but 9 days before first scheduled date of apheresis. That's because due to the chemotherapy, our patients go into aplasia. The dose is the same, of course. There is a CD34 count the day before apheresis. The most used chemotherapies in mobilization are ERDAP, ERCHOP, ERCHUP, and ERICE, but also high-dose cyclophosphamide, for example, in multiple myeloma patients. Some hospitals like to use it, others not, because it has a lot of side effects, especially located in the kidneys. So what is the role of the chemotherapeutic agents in mobilization? And there are two roles. So first of all, it's a stimulus for mobilizing hematopoietic cells to the peripheral blood, so from the bone marrow to the peripheral bloodstream. And in multiple myeloma patient, it also has an anti-myeloma effect. Then the use of plerixafor and pore mobilizers. First of all, what is a pore mobilizer? Risks to be a pore mobilizer is increased age. So how older you are, the more risk you have to be a pore mobilizer. Prior treatments and cycles. So the more treatments or cycles, the more risk you have to be a pore mobilizer. Also extensive disease burden or prior use of thalidomide. And of course, if you have evidence of poor marrow function. Plerixafor, also known as Mozobil, is shown to improve CD34 cells collection in combination with the growth factors. So what do we call a successful apheresis? When we have a minimum of 2 × 10⁶ per kilogram for a single transplantation and 4 × 10⁶ per kilogram for a tandem transplantation, so double transplantation, or patients that are younger than 65 years old. Most of the time that are multiple myeloma patients for the double transplant. How do we do the calculation? So we get the CD34 count from the lab. We do that times the volume that we collected, divided by the body weight of the patient, divided by 1,000. And then we have our CD34 count times 10⁶ per kilogram. So then we know if we have enough. So the minimum is 2 or 4 for a double transplantation. Be aware that the stem cells for autologous stem cell transplantation are cryopreserved, so we have to take into account the loss of stem cells during that freezing procedure. So what do we choose, whether or without chemotherapy? Of course, that decision is always made by the medical team, but here we have a few examples. So the disease itself, then the treatment that is given, because some chemotherapies work more mobilizing than others. Of course, as mentioned before, the previous lines of therapy. If a patient already has a lot of lines, already received a lot of lines of therapy, then it's possible that we choose to do a collection en blanc, so without additional chemotherapy. A little side note there, for the collection of donor lymphocytes or T cells, we don't have a mobilization procedure. Then the second type of donor is an allogenic donor. Then we have 2 types of allogenic donors, so an MRD, so matched related donor. First line, sisters and brothers. Second line, mother or father. Then we also have the MUT donors, so the matched unrelated donors. They can be found in a donor bank worldwide. So I'm going to take advantage of this situation to encourage everyone to register as a stem cell donor, because in my work experience, I can say that it could save lives. The procedure of mobilization is actually similar to the process of an autologous en blanc collection, because, of course, we will not give chemotherapy to a healthy donor. So also 5-day mobilization, the dose is also the same, no CD34 count at the day before apheresis, and the pre-count minimum is also 15 or more. What is here is successful apheresis if we have a minimum of 5 times 10 to the 6 per kilogram. The calculation is the same, but pay attention, here you have to use the body weight of the patient and not of the donor. Normally, these cells are administered fresh, but due to COVID measurements like high infection rates and transportation issues, we still ask to cryopreserve the allogenic stem cells. What are the possible side effects of mobilization? The bone pain of the growth factors, because the stem cells want to go from the bone marrow to the peripheral bloodstream. So they actually press against the bone. That's why you have, can you experience bone pain? Of course, you can have paracetamol for that. And also the feeling of having a little fever. Then the collection, most common are dizziness and tingling during the collection time, pain or bleeding at the insertion point of the needle, and of course fatigue, so being very, very tired. Contraindications, so if the donor is known with a known allergy of the growth factors, if there are side effects after the previous use of growth factors, and of course pregnancy or breastfeeding. In allogenic donors, I'm going to tell a little bit more about that later in the presentation, but take in mind that, there is a great importance in prior donor assessment. Little point of attention there, don't forget the psychological effects when you can't be a donor. So if you can be a donor for your sister or brother, we have to take that into account. Donor education. So our doctors and or nurses and myself, of course, explain to the donor how an apheresis procedure works, what the possible side effects are, how to store, prepare, and give the growth factor injections. Point of attention there, very important, the donor and patient's information is strictly separated, even if it are brother and sister. The importance of screening and follow-up. So for screening, the main question is this a suitable donor? How do we check that? A good anamnesis, that's actually the key. So we check the medication list, the medical history. We have a very long medical questionnaire. And of course, also prior to the donation, we do a blood draw. In that blood sample, also the infectious disease markers are tested. Take into account that you have to notify your donor if you test, for example, for HIV virus. And then, of course, the importance of a detailed information session before the donor gives his or her consent. That's very, very important. The follow-up. That's actually the last part of my talk here. So after a week, in our hospital, it is after a week, the donors come back to see if the blood levels are stabilized after the apheresis. That's actually the main thing that we do to see if the donor is okay after the apheresis. And then, of course, we have a long-term follow-up as well. After a few months, after a year, and then every year, we go and check with the donor. Take in mind the psychological effects. For example, patients with MS who have to undergo a stem cell transplantation never received chemotherapy before. So this will be the first time. So as a nurse, you have to be very alert for that. And also, as I mentioned before, if a brother or sister or parent can't donate for their child or brother or sister because they are not suitable, take into account the psychological effects of that. So as you can see, there is a very, very important role for the nurse practitioner, the nurse specialist, or the coordinating nurse. Thank you so much for your attention and having me, and have a good end of the day. Thank you.